Hello and welcome to a live event with the University of Chicago Medicine. I'm Tim Brown, and joining me is Dr. Kyle Hogarth. Thanks for being on our event today. I was going to say the program. We'll call it a program. Why not?
That works.
Dr. Hogarth is an expert on asthma and one of the few doctors to do a very specialized procedure called bronchial thermoplasty. In fact, if I'm not mistaken, you were the first doctor in the state of Illinois to do that, and I think you told me before the show, third doctor in the United States, correct?
Sounds about right.
Yeah, well, so very good. That's interesting. And throughout this live program, kind of the neat thing about Facebook Live is you can actually send your questions to us, and we'll try to get them answered as best we can.
Sure.
So that'll be a lot of fun. Also, we want to remind our viewers that you can go to UChicagoMedicine.org for appointments and more information. You can also call Tanya, who is Dr. Hogarth's scheduler, at 773-795-9933. Yep. Let's get right into it, and we'll start with kind of a basic, if you can just tell us what exactly asthma is and how do you know that you have it?
That's a great question because there's probably actually a couple $1 billion in research grants that have tried to answer specifically what asthma is, but I guess probably the simplest way to describe it. It's a disorder where the bronchial tubes, the tubes that all the air is moving through in your lungs, will essentially tighten up. They will constrict. So instead of being big, they will become much smaller. Mm-hmm. And as that happens, and it usually happens from many different things, triggers of irritants in the air, ozone, pollution, etc., smoke, or things that you're allergic to, pollens, cats, dust, etc. That constriction obviously makes it very hard to breathe, and so you'll have symptoms of wheezing and cough and shortness of breath and chest tightness, and you might not be able to, especially if you're a younger child, not be able to keep up with the other kids on the playground, etc. If you're playing sports, maybe you have to sit out for a little bit. Ultimately, though, those symptoms can come from other things. So just because you might have that feeling doesn't mean you're automatically an asthmatic. That's actually where you go to see your physician and get evaluated. There are a series of tests and ways to prove that indeed you have asthma. And I think it's important, though, because not everything that wheezes, just because you make a whistling sound or tell me you have trouble breathing, doesn't mean you have asthma.
Yeah. So if, as a parent, if you see your child struggling, what are some of the things you look for and triggers that trip to the doctor?
Yeah, well, I'll use my a relative as an example, because I had a relative who was a child who, as I was watching him not be able to keep up with my son on the playground, and not be able to climb the monkey bars and run around like any other little kid ought to be able to run around. And he would stop, and you could see that he was sort of breathing heavy, and he wasn't able to vocalize, chest tightness. He was a little guy. But I said, we need to go get him checked out. And obviously helps that this is what I do for a living. And so, sure enough, no surprise, he actually had asthma, and once properly treated, did fantastic. I think it comes down to watch how you're, especially if they're younger and they can't vocalize, watch the breathing. Does it look like they're having trouble breathing? And then usually the first clue is just that simplicity of not being able to keep up with the other kids in general, right?
Yeah.
So.
Yeah, interesting. So I would imagine it's like many other conditions. You have different levels of severity and different levels of treatment. So.
Absolutely, and there are, of course, published guidelines that help guide physicians on how to manage the disease with the patients. And those guidelines offer an array of medications, and there are actually plenty of medications, thankfully, that to help with this disease. It's actually been one of the nice advances within our field that asthma has become a disease that we have a lot more options. That way, if some patient is on a medication but dealing with side effects from it, we've got other choices. And obviously has allowed something from a competitive perspective that with their insurance, they can potentially get some of these drugs pretty cheap. Depending on your level of severity, and there's lots of ways to measure it. We usually, of course, simple questions of, is asthma interfering with your daily life? Are you waking up at night? Are you needing your rescue inhaler? Have you had to be in the emergency room or on oral steroids, drugs like prednisone? Those are all signs of obviously not enough control. And if you're not on enough control, then whatever drug regimen you're currently on, assuming you're taking it, is not enough. And I'm going to segue there for 1 second and say probably the most important component of asthma management is that the chronic meds that your physician has said you should be taking, you need to take them. And if you're having issues with them, don't just stop them, but communicate with your healthcare provider, because without a doubt, we have other options. And so if you're having a horrible side effect from whatever drug, let that person know. We can try something different to try to control your disease. The rescue inhaler, albuterol, whether that's nebulized or a handheld inhaler, that actually doesn't treat asthma. All that does is treat symptoms of asthma. It helps relieve the bronchoconstriction, but the underlying disease of the inflammation and this muscle constriction, it's not treating at all. And so if you're taking albuterol, you're not helping your disease. And that's actually a measure of poor disease control.
So you're just helping that immediate symptom
Yeah.
at that point. And along those same lines, I'm kind of curious. I imagine you probably have a lot of patients, like any other doctor, that when their symptoms improve just a bit, they will stop taking their medication because they figure that they're okay.
They're okay.
Not a good idea.
Well, it's not a good idea because obviously the underlying disease of asthma is still there. And it's an inflammatory disease. And it's over time has the potential to do real damage to your lungs, to where, you know, I did the demonstration earlier of a big airway that constricts down. It then ought to pop back open. But over time, it has the potential to not do that. And so your lung can start to stay more constricted. So as you age, there is that potential that you will not be able to breathe like you used to, and that your best days are not nearly as good as they used to be.
Yeah. Got a question from a Facebook viewer. Robin asks, or has a question. I have difficult to control asthma as described by my pulmonologist. So do you see patients like me?
Yeah, so that's I guess at the core, that's what a pulmonologist does. That's what we all do. And in particular, you know, my work here and the one procedure we offer, which we'll talk about ultimately, it's a specialized procedure, and only so many people do it, et cetera. But we built a clinic specifically to see people whose asthma has been difficult to control despite the medical management they've been on. So, of course.
So how about like pollution, air quality, things like that? How much of an impact does that have on it?
It plays a role. I mean, it's like all things, it's variable. It's going to depend on the patient. You know, one of the questions I ask when I first meet a patient is, what are your triggers? What sets off your asthma? And, you know, here in Chicago, it's, you know, there's certain days I look downtown, I can't see downtown, right? You know, the ozone's high, it's, you know, 100 degrees out, humid, et cetera. You already know how your asthmatics are going to do. I'm actually a bad asthmatic myself. I know how I do on those days. So, you know, they're not kidding when the newscast says, we want to stay indoors that day. And when your doctor says it, we're not kidding either.
So just curious, you have asthma.
Yeah,
I
do.
Is that what caused you to do this for a living?
Probably. I'm sure it indirectly influenced it in some capacity. Now, I will tell, and everybody should know, it's unbelievably well controlled, not because I do this for a living, because I actually take my medications, believe it or not. So the inhalers that my doctor prescribes, I don't prescribe myself, my doctor prescribes, I take them as directed, and lo and behold, it's under control. And I will attest that, you know, didn't time things right once, was on a vacation, out of the country, ran out of my inhaler, my controller med. Oops, and you know, guilty. And 4 days later, there I was struggling to breathe and pumping down albuterol until I got back into the U.S. and got my inhalers.
Wow.
And so, you know, it's a controllable disease on average, and that comes back to you asked about severity. There are clearly some people that their disease is worse than others, and the level of drugs required is, you know, higher than their neighbor, if you will. And then in some people, we've got some really good drugs, but their disease is worse than the drugs we've got. They're above that. And those people definitely suffer a lot. And there is a workup we do to try to help figure that out. And then ultimately, when the drugs aren't enough, that's where procedures come in, or some of these newer drugs that are injectable have a potential to help patients as well.
Now, I've got a relative, and I've been dying to ask this question, who has a child with asthma.
Yeah.
And they've kind of got a little bit of a war going on within their family about pets. The kid wants a dog.
Yeah.
Mom doesn't want the child to have a dog because of the asthma.
Yeah.
What are your thoughts on that?
Well, it's partly going to depend on, is the child essentially allergic to dogs or not? You know, if they're not allergic to pets and they've been tested and they're for allergies and they're not allergic to a pet, there may be a reason not to get a dog for other reasons, but it would be hard to say that that's the etiology of their, you know, worsening of their asthma. Now, that all being said, you know, tried and true methods of helping with asthma management, they're not perfect, but clearly allergen and trigger avoidance is always a good thing. You know, and I'll hear people say, oh, you know, if I'm around smoke, it doesn't bother me. It does. You may not feel it. You may have gotten used to the symptoms. There's no way cigarette smoke is not remotely, you know, harmless to someone with asthma. It's harmful to everybody, but especially people with asthma.
And I would imagine you may not feel it right that second, but it'll probably...
Well, sure, the underlying inflammation's still ongoing. And then on top of that, remember, you know, we all get used to certain things. Like anything, you know, if you have a certain level of shortness of breath that you've just, quote, learned to live with, well, that's also unacceptable. And that's one of the other reasons that when people will say to me, oh, you know, I only use my albuterol, you know, 3 times a day, and I wake up twice at night to take my albuterol, that's okay. Like, that's not remotely okay. That is asthma dictating your life, not the other way around.
That's a great statement. I think that's very interesting. Amanda has a question for us. She says, in people with difficult to control asthma, why do some preventative drugs seem to work for some time, then stop working out of nowhere? She says she's tried various things over the years, and it seems that it's almost random when her asthma decides that her current medication just isn't good enough anymore. Yeah,
it's not. So the short answer is don't know. That's the easy short answer.
That's an honest answer.
It's an honest answer. It can be a lot of factors. So not specific to this person, but you know, in general, is the inhaler still being taken properly? You know, if the medicine only works if it's appropriately getting into the lungs. There are many other things that can influence difficulty breathing and asthma. Like I said at the very beginning, is do you actually have asthma? And I bring that up because a lot of patients have been referred to our center for the bronchial thermoplasty, and you know, because, quote, my asthma's so out of control, and when we actually evaluate them, we actually discover they don't even have asthma. And that's actually doesn't happen frequently, but it doesn't happen rarely either. And that's why I said at the very beginning, just because you're having trouble breathing or wheezing doesn't mean you actually have asthma. And if the appropriate testing hasn't been done, it's an easy label to slap on a patient. Oh, you have asthma, take an inhaler, get out. But it's not always appropriate. Now, there's other, so what I guess I would say for that person is there other disorders? I will say too frequently that when someone's had difficult to control asthma, they frequently get put on prednisone, oral or Medrol, oral steroids. Those are notorious, obviously, for weight gain. If you've had large swings in your weight, that alone will give you significant difficulty breathing. And so suddenly it's not so much your asthma, but it's your obesity that's giving you difficulties with your breathing, or both. And so there's lots of other potential factors.
Interesting.
Yeah.
Joyce has a question for us. She says, do you recommend your patients use Flowmeters?
Oh, the peak flow meter. It depends. It's a tool. It's a useful tool. It can be part of an asthma action plan, so that if you're not really clear on your symptomatology, as a way to measure, you know, essentially your ability to blow out, and if it starts to drop, you can initiate an asthma action plan. Some physicians really like using flow meters, some don't use them. They are a useful tool. I think they're valuable in a scenario where some patients don't necessarily notice symptoms until they're having a real severe exacerbation. So the advantage being of catching it a little bit earlier, it's sort of the canary in the mine long before you're suffering, at least feeling like you're suffering.
Interesting.
Yeah.
So Paige has a question for us, and she says, or asks, do all types of smoke aggravate or trigger asthma? And she's thinking bonfire smoke, car exhaust, cooking smoke, etc.
I mean, so the short answer is yes. I mean, in the sense that, and I should point out too, so, you know, cigarette smoke obviously is the easiest one, but, you know, marijuana smoke is the same idea. Smoke is smoke.
Yeah.
You know, I will ask my patients when they come to asking them essentially what they're smoking. Yeah. I explain to them, look, I'm not the police, I'm not your mom, I'm not here from some moral perspective. I care about your health.
Yeah.
I care about what you're putting in your lungs. Now, you know, when you ask about other smoke, one of the most common causes of emphysema in developing parts of the world, where there's not necessarily a lot of smoking, but it is closed environment, cooking over an open biomass, a lot of smoke. Well, it's all relative, though. I mean, you tell me that once in a while you like to be outside near a campfire, and I suppose my advice would be don't be immediately downwind sucking in all the campfire smoke.
Yep.
But if we have your asthma under good control, you know, that comes back to my earlier statement: is asthma controlling you, or are you controlling your asthma? You know, you ought to be able to still enjoy the things in your life that you enjoy. It's that dose of being, I suppose, rational. You know, let's try to minimize it, but you know, if you like to cook, you're still gonna have to cook. So.
Well, we're getting a lot of smoke questions. We've got another one. What are your thoughts to correlation to asthma and secondhand smoke, and is vaping any better?
Vaping.
I'm sure you've heard that one a few times.
Yeah. So the short answer on vaping is Not better. Number one, there's no regulation and control of what you're actually putting into your body.
Yep.
So there's this thought process that it seems, quote, healthier. I suppose it's all relative. I got asked this question once by a junior high student who was really insistent on whether or not cigarettes or vaping or like a pipe or a cigar, which one was the safest. And I answered back, I'm going to put in front of you 4 different weapons. Which one do you want to be killed with? And because one, it might be safer than the other.
Parents everywhere are thanking you right now, by the way. So
no, I mean the point being, it was they kept like, but what if?
Yeah.
And basically the answer was they're all harmful. Yeah. Sure, I mean I suppose if someone it shows me data that says such and such is less harmful, but in the end they're all harmful, right? Yeah. A larger caliber weapon or a lower caliber weapon both shoot me. So guess what? No good answer from a safety perspective. Your lungs are a very precious organ. It's the one organ that's exposed to the outside world. And we have at least some say over what you put into your lungs. I mean, no, you can't control what's happening in the air, around you and you walk outside kind of thing. But you can definitely control what you're putting in. And I guess my short answer, too late, I know I like to talk, is there's a lot of things in this world that are going to harm you or kill you for free. The idea that you want to spend your own money to do it yourself seems nuts.
That's a good answer.
Yeah.
It's a good answer. So apparently we have a few physicians watching too. And
Hey.
Christopher is one, and he said, when should we primary care docs refer for thermoplasty? So let's talk about that, and let's also just talk about thermoplasty in general. Can you start off kind of describing what exactly it is?
Oh, okay, yeah. So bronchial thermoplasty is unique in the management of asthma because it's actually a procedure. So whereas every other intervention that we do for patients, take this inhaler, take this pill, it's a medicine. It's an inhaler or a pill or an injection. Mm-hmm. But thermoplasty is a procedure, and it's done bronchoscopically. So sedated a patient. We at our institution we do ours under anesthesia, so you're out as if you were having an operation.
Yep.
But we go right through your mouth into your lungs, and through the scope. So we have a tube with a camera on it. We go in and take a look, and the way thermoplasty works is it uses energy, and it actually heats up. That's the thermo part. Mm-hmm. Heats up the airways, and it turns out that the muscle that wraps around the breathing tubes that causes that constriction is very sensitive to heat. And by the act of heating up the airways, you are able to hopefully minimize how much symptomatology your patient has, and they can do better with their asthma. And of course, this has gone under lots of different studies and trials. It was FDA approved 8 years ago based off of literature that demonstrated that on average, the patient felt better, went to the ER less, and had overall less symptoms. One key thing to point out, not everybody. So you might be the ideal patient for thermoplasty. The one area that we haven't yet figured out is, can we tease out who will respond and not respond? From the medical literature, it was an 79% response rate that the patients improved. But that does mean roughly 20% of people didn't receive a clinical benefit from it. Now, what I always point out, and I wish I had 100%. If I knew how to say you wouldn't benefit, that'd be great. But by definition, if you're a patient who's already not responding, you're somebody who isn't responding to the drugs we have. So, these drugs don't have a 100% response rate either. None of them do, because if they did, you wouldn't have needed thermoplasty to begin with. So, who should be referred for thermoplasty? If you're on maximal medical management, so I have you on inhaled corticosteroids at the max dose, a long-acting beta agonist, and so there's a lot of drugs on the market that are a combination of those. Plus or minus, I've done things for your allergies and so forth. I might have you on another inhaler that's called a long-acting muscarinic to help open up your airways more. And despite all that, you're still having high symptoms. That if we use some of the symptom scoring tools, that your symptom scores, the way the scale works, low is bad. So your scores are low, bad. You're having needs for albuterol at night. You're in the ER. You're on prednisone yet again. 2 times a year is unacceptable. So it's not this healthy level of prednisone. You never should be on it. That's someone at least thermoplasty should be considered and be at least evaluated for. Or some other form of an intervention. Maybe it is the injectable drugs, maybe it's thermoplasty. But the notion of just putting you on prednisone again is unacceptable.
Now, if a person has successful BT,
Yeah.
do they continue to take medication, or?
Great question. So this is obviously a supplement to your medication. I mean, there's never been a study that said, we don't cure asthma. But I would love to cure asthma. It'll definitely be way smarter scientists than myself who figure this out someday. This is an add-on therapy. The nice thing, of course, is that we do it, and if you get the benefit from it, the literature has also supported that the effect lasts. And so if we do it, and you feel better from it, that effect will be maintained on average.
Right.
Clearly, everybody's response is different. I'm sure there's people watching who've had it and didn't get a benefit. I'm sure there's people who got a massive benefit, and everywhere in between. But what inhalers you'll be taking and pills and whatnot, you'll still be on those. You might make changes. That'll be between you and your physician, obviously, as far as can we dial down. When the literature showed as far as like ER visits and exacerbations and the need for prednisones and all that, nobody walked away from it. It's an issue of, there's one patient of ours who's had a very profound response, and he had spent many nights in the hospital. And after thermoplasty, went down to basically one night, which is still, I'm not happy about. But it was clearly a massive improvement, but not a zero, I'm never going to be sick again.
Yeah.
And so I think that's the other key component of probably any intervention, whether it's one of the injectable drugs or bronchial thermoplasty, is that setting realistic expectations.
I have another one from a physician. It's kind of a broad question, but
All right.
I'll let you take a shot at it. This is Kara, who wonders what your thoughts are on how we can work together with our patients on taking their asthma medications so they're in control of their asthma. And again, it kind of alludes to one of the things we talked about earlier, is getting these patients or any patients to take medicine.
Well, so, it's a chronic condition, right? If you have high blood pressure, you need high blood pressure pills. If you have diabetes, you need to control your diabetes. And this is always that important education component. So the analogy I use, and it's a silly one, but if my leg is broken and you give me morphine, it won't hurt, but I very much still have a broken leg, right, until you fix it. So if I give you albuterol, yeah, you feel a little bit better. But the underlying inflammatory disease, the disease that is asthma, is not remotely being treated at all. And so that's the problem. And so if your doctor says, look, I want you on this inhaler, whatever it is, and it's some form of an inhaled steroid. I want you taking it once a day, twice a day, whatever. Please do so. And you'll say, well, I don't notice anything from it. You're not going to notice anything from it because it doesn't open up the air passages like that albuterol does.
Yeah.
But if you pay attention, what you are going to notice over the next several weeks is that you're not reaching for that albuterol, that you're not having to go to the emergency room, that you're not on oral steroids again. It happens once in a while. I had a patient who, adherence to their meds was a problem. We had a sort of nice heart-to-heart about it. She got it. I said, just do me a favor, humor me for the next month. Just take it no matter what, no matter how stupid you think I am. Just do it. And when you come back, let's talk about how much albuterol you used. She came back, and lo and behold, she was like, wow, I've never felt this well. I was like, yeah, there's no secret here. I gave you a standard, an asthma inhaler, but you took it, which was the key difference.
I think ultimately, and I completely understand this, nobody wants to be on medication, so they hope that they're cured and they can, but it's just not the case. And if you want to feel better, you need to continue to follow your instructions.
Well, and that's the thing too, is so someone says, I don't want to take these medicines, but they're puffing down albuterol all the time. And I will tell you that every time you need prednisone, and I guarantee you there's people watching this who have been on prednisone. I've been on prednisone. That stuff's poison. And look, I use it if I need it. I want my patients on it. It does what it's supposed to do. It's a good drug when you need it. But it's a horrible drug and fraught with side effects, and especially long term. And it is not a solution. It is when you have truly nothing else to offer when prednisone is considered the answer. And I have better have exhausted every other thing in my toolbox before I'm going to condemn you to chronic prednisone.
A couple more BT questions. Joyce asks, what are some of the side effects and complications from the procedure?
Yeah.
Is it a one-time procedure? And we had another question earlier, too, that asked about recovery time.
Yeah, you bet. So it's actually done through 3 separate bronchoscopies. So 3 separate times you're put under We, by convention, do the lower part of the right lung first, then the lower part of the left lung, and then both upper parts, the remaining real estate.
Is there a healing process? Is that why you do one?
Well, so all the original studies, the thought process was you should give people some time to recover. And you definitely, when we do the first thermoplasty, what the data supports and what I tell all my patients, look, you're going to feel not so great for a few days, probably up to about 5 or 6. Everybody's different. Clearly, some people fly right through the procedure, and some people have a pretty rough time. The shorthand is I say, look, if your procedure is Thursday at 8:30 in the morning, that's when you're having an asthma attack, because I'm going to give you one, because I'm going to go in and irritate your airways on purpose. So, because it's an elective procedure, if you tell me you got some big family event that weekend, we're not going to do your thermoplasty that week. Now, why do we wait 3 weeks? All the original studies, that was the protocol. And so that's how we know the safety record. And so the reason I don't deviate from the 3 weeks, I'm sure we could, but I don't have literature that backs up that it's as safe if you're doing it more frequently, like every 2 weeks. And what's the hurry? I mean, I want to know safety first. I mean, I want this to help you, obviously, but what I really want the most is to know that you're safe. So in the published literature, all the trials that were done, it probably goes without saying, but no one died. And that is, I think, seems obvious, but boy, that's great to know.
That's positive,
And once the final procedure was done, and a few weeks passed, is when then the symptom improvements were noted by everybody. So what I tell people to expect is that for the week after each one, you're probably not going to feel so great. You're going to be using your albuterol more. You're going to feel a little wheezy, a little kind of beat up. Some of that's an anesthetic effect. Some of that's us, in there with the thermoplasty.
But can they go to work and do?
Yeah, no. Typically, if we do it on a Thursday, I tell people you're going to go back to work probably on Monday.
Okay.
Yeah, just not going to have the greatest weekend.
But just take it easy and don't.
What ends up happening, like I said, and then people come back on Monday. The next time I see them, and they'll say, "Wow, I thought you said I was supposed to feel lousy." I'm like, "Sorry, I'll do better next time."
It's a good problem to have.
Yeah.
Andrew has a very interesting question. I hadn't thought of this one, but it's a great question.
Yeah.
What's your opinion on the risk of scuba diving with asthma?
And
are there any additional safety steps that can be taken to reduce any risks that you might have?
So I am not a dive certifier person, so I'll give you sort of the generic answer. The concern for bad asthma or any asthma for diving is multiple. One is, of course, you start having an asthma attack and you're down however many feet, not going to be able to reach for that albuterol inhaler.
Yep.
And can't ascend rapidly either. I don't dive, but I know what the bends are. So there's your first sort of barrier. But the other problem ultimately, and the whole issue, of course, with dive medicine, if you will, or diving in general, is as you are rising, gas is expanding. And because asthmatics have such variable degree of constriction and opening of their air passages. It's not, every time I do my, hands and shrink them down, that's happening globally, but at differing degrees. And so the concern is that an area that got closed down has a lot of gas behind it that you can't exhale, and it's now expanding, and then it ruptures, and you develop a pneumothorax is what it's called, where your lung essentially ruptures, collapses. You can imagine that that's never a good thing.
Yes.
But it's especially not a good thing underwater.
Wow. So a suggestion for divers, maybe take up snorkeling.
My understanding is that technically speaking, asthmatics are not supposed to be certified for diving.
Interesting.
Now, I could be wrong, so don't, that's not.
Yeah, it makes sense.
But
yeah, so not a good idea.
So I would love to dive. I have friends who dive, and I have not been a diver secondary to my underlying lung disease. But I snorkel.
Yeah, there you go. So let's talk a little bit more about BT.
Okay.
One of the questions we had is referencing safety record for the procedure.
So I mean, the safety record is actually quite excellent. Both on our institution and then what's been published in the medical literature. Like I said, no one has died. There's not been lung collapse, puncturing or popping of the lung. There's definitely been worsening of asthma. There is a small but real rate of likely having to spend the night in the hospital, maybe even a second night in the hospital because of worsening asthma. We do, around the time of the procedure, we do put you on oral steroids, the drugs I tell you I try to avoid, but those are needed for a flare, for an exacerbation, and I'm essentially going to give you one, so we pre-treat. Now again, that's from all the original research. That was the safety protocol. This is how we know to do BT safe. That's what we stick to. Is I'm not going to deviate from what I know has been a proven track record of safety, because that's what matters the most.
Yeah. Interesting. So you mentioned a little bit, and I wanted to kind of get some clarification on this, because you were talking about different portions of the lungs having different levels of, I guess, asthma attacks or different levels of issues. So how does that work? So you may have worse symptoms in one area than another?
Well, it's not necessarily symptoms, and you wouldn't feel it from a localization process. It's just that the disease itself is very heterogeneous in that it's diversified throughout the lung, and so it's not that necessarily one area is always worse than the other. But that's the problem from the diving perspective. Yeah. But and the way we do the procedure, the application of the heat's through a catheter, and so essentially we go into your airways and sequentially just keep hitting the next area. So it's almost like we're painting the airways. Obviously we're not painting, but the idea is move it on this area, back it up, move it onto this area. There's videos online. I think we've posted some, I'm sure all over anywhere else, if people want to see an actual thermoplasty procedure and the catheter, and the manufacturer I'm sure has that as well on their website. So.
Yeah. So if a person has asthma and they're seeing their family physician and they're having a relative, and I guess it depends on the person, but degree of success with their treatment. Yeah. When does it get to the stage where you step in, where they call you and say, hey, maybe we can do a little better?
Yeah. So I'll give you a great example, because I'm on maximum. So I'll use me as an example. Yeah. So I'm on the highest dose inhaled steroid, and I'm on a long-acting beta agonist, so I'm on maximal medical management. So then why have I not had thermoplasty? Because I also have no symptoms, no exacerbations. I've been on prednisone in years. Now, I used to be on a lower dose. My disease worsened. I needed a higher dose, and now I'm under control. If the day comes where this isn't enough, there's no way I'm going on chronic prednisone. And so this would then be my next step. But when I have no exacerbations, no symptoms, what would thermoplasty do for me? Nothing. There's nothing to fix here, if you will. So, what ends up happening, and this is important, because when we first started doing bronchial thermoplasty, once it was FDA approved and we opened up our shop and said, okay, let's see people, a lot of patients were sent, but these were extremely sick patients, people who had been on ventilators for their asthma, who were never off of prednisone, et cetera. And that's definitely, the word, severe clearly means lots of things to lots of different people, and there's a grade there. I guess you could use the word very severe and then severe. But if you've needed oral prednisone twice in the last year, then your asthma is not under control. You're allowed one, basically, because it's a variable disease, and this was one heck of a winter. If you picked up some bad viral thing and the flu and anything else they went through, and you needed oral steroids, sure, you get a pass. That's not your disease under control. You got hit hard with a bad bug. Okay. But if now it's spring and things well, not yet, but soon spring, at least by the weather, we're getting there. You're now needing your prednisone again. And then this summer, of course, once it's 100 degrees out and hot, and you're going to need it again. How is that acceptable? It's unbelievably not acceptable.
Are there any times of year that are more?
Depends on the patient, right? I mean, it depends on what your triggers are. If you're really allergic to pollen, you can imagine springtime is not your friend. Yeah. If cold air is one of your triggers, then you live in the wrong city. At least if you're a Chicagoan watching this.
Yeah. So one of the things I'm always kind of curious about when a parent or child, child has asthma, a parent knows their child has asthma, I think oftentimes they look at that like, oh gosh, this is a kind of a life sentence on this disease. Yeah. And I guess to a degree it is, but there is hope.
Oh, very much so. And I probably should point out, since we've been talking about thermoplasty, it's not indicated for anyone under 18. Okay. So unfortunately, there are, if you're on maximal medical management, and one of the injectable drugs is available for children, but this procedure is not. I guess there's two ways to look at that, and it's all how you want to spin it. So yes, it is a lifelong disease that has a variable course. So some people, quote, outgrow it. I'm not a fan of that term, but for reasons we don't understand, or at least that I don't understand, their disease severity seems to decline and to the point where they really are symptom-free. But I suppose what I guess I would say is it's a manageable disease, and that unlike some other disorders, just of the lungs, let alone any other organ, where there isn't a therapy, that you've been told you have such and such disorder and, good luck. At least here, there's definitive hope. And, no debate here, tons of research going on. There's a pipeline of medications coming down the pipeline. I used that word twice, my bad. But there is a
That's all right.
plethora of drugs coming down the pipeline. We've got lots of options. And that's the thing too, because no one is satisfied, right? Until you're under perfect control and you're not needing your albuterol. If I walk over to my emergency department, there's not a row of asthmatics waiting to be seen, then our job's not done.
Yeah. Can people be too sick for PT?
That's an open debate. In the literature for the studies that were done to evaluate the safety and efficacy of thermoplasty, like all studies, there was here's who we want, here's who we can't take. And the who we can't take had groups that were, quote, too sick, chronic, higher doses of oral prednisone, been on ventilators, have near-death experiences with asthma. Now, it's understandable if you're trying to study the safety of a device, you want sick, but you don't want that level of sick. The problem is of course, there's a lot of those patients. So our center and several others have actually, if you're a candidate for thermoplasty, no matter how, quote, sick you are, if you're a candidate, we've proceeded. And so we have presented our experience with that and published one small paper on that, and others have as well. And to date, kind of the brief summary of it is, it looks to be safe even in that population. Now, clearly, a sicker patient, you need a experienced bronchoscopist who has experience in thermoplasty and severity of managing severe asthma. You need a good anesthesia team that knows how to manage these patients as well. So, like all things, is definitively a team approach. That is not and in particular for the more severe, if you will. That's all relative, but I think that's one of the things that I'm lucky. I get to work with some fantastic people. And so the experience within our clinic and our anesthesia team and the recovery and so forth, is excellent. I'm fortunate to work with some ridiculously great people.
That's great.
Yeah.
Michael has a question for us.
Yeah.
He says, what role does weight play in asthma control?
The short answer is obesity is horrible for asthma. I don't want to get too technical, but let's just make it real simple. Your lungs are the only organ that really needs to do a lot of moving to work. I mean, the heart's obviously doing its thing, but the lungs have to expand. And if you're overweight, your lungs are being compressed, pure and simple. And everyone has experienced that, because if someone's giving you that big tight bear hug, you were a kid and your uncle came and gave you the big squeeze, you had trouble breathing.
Yep.
Well, if you are 100 pounds overweight, 50 pounds overweight, you're being squeezed. And even people who are not overweight have had the experience of what it's like sort of acutely. And what I mean by that is, let's pick a typical Thanksgiving meal. When you went back up for thirds, right? And your stomach is all bloated out, and just because you've obviously put a ton of food in, you can't breathe very well. That's not because you're obese, it's because you're very full. But remember, diaphragm's right here, that full stomach, pushing up. Any woman who's been 8 months pregnant will tell you how difficult it is to breathe.
Yeah.
Because there's a baby in the way. They're not fat, there's a baby in the way. So, to extrapolate that, you've got actual obesity. So the short answer is, easier said than done, but weight loss will dramatically improve asthma.
Yeah. Lewis asks, outside of prescription medication, are there any natural remedies that help alleviate an asthma attack?
Great question. The short answer, none that have been proven. My sort of general answer to the over-the-counter, natural, whatever word you want to use.
Sure.
It's an important thing for people to remember one key thing, which is by law, over-the-counter remedies that are not a drug, but that are so-called natural, or whatever word you want to use, are not required to have proof of efficacy, and are not actually even required to contain what the box says it contains, which is shocking. But when you read the law, it's actually kind of scary. Now, that doesn't mean, of course, if you tell me you took some supplement, and it's helping you, that's awesome. I have no problem with that. And I've had people say, well, maybe that's the placebo effect. Well, what's wrong with that? If you feel better, I'm happy. Now, where I get concerned is what's really in what you're taking. Are you putting something that's potentially toxic into your body? Or number two, those things are not covered by your insurance plan. And so if you can afford them, great. But what I get worried is when someone says, I can't afford the inhaler that you've prescribed for me, Dr. Hogarth, but here are the 5 supplements I'm on. And those are, $12 here, $25 there, et cetera, et cetera.
Stephanie has a question for us. She says, have you had success with Biologic injectables for severe asthma, and how would you best identify those types of patients that would respond?
Absolutely. So there's been a lot of advances. There's been the classic, it's called Biologics, and the idea is that these are antibodies that specifically target various molecules in the body that are thought to be involved in asthma. There's been one on the market for some time that targets IgE. There's been several that are new to the market that target interleukin-5, which is an inflammatory mediator in asthma. And they all got approved because they were demonstrated in their studies to improve asthma in specific types of patients. And I use these drugs as well too, and have had patients on them with success. And of course I've had patients get started on these meds without success. Because like all things, there's a bell-shaped curve response. So, this may be the greatest, newest drug, et cetera, and you start the patient on it with the best of intention, they meet all the criteria, they would have been in the study, et cetera, and they don't get any benefit, or they only get side effects, and sadly does happen. But I've had the opposite. I've had people where you've started on some of these drugs, and it's been wonderful. The patient will use the word miraculous. Now, how to determine it? Well, each of these specific drugs have their criteria as far as what they're indicated for. So it's not just bad asthma, there's lab work that indicates that you're a candidate for these, and people should consider that for sure, and we do as well. They are injected. You have to go to a clinic or some facility. They're not done at home, so that's maybe the downside, if you will. It's not daily, it's at various intervals of weeks to months. So, in the end, it's like all things, or at least how it should be, it's a shared decision model. If you get sent to me for bronchial thermoplasty, we're not doing it that day, and you can say no, and you may not be a candidate. And you might come to me and say, I really want to be on one of these injectable drugs I just read about, but then when we do the testing, you're not a candidate for it because you don't have the marker for what these drugs attack. And so we know they won't work for you. You won't get approved for them. Yeah. And so I think for people who manage severe asthma, where, like I said, things are exciting, is we've got more tools in our toolbox. And when I get asked, like, well, what if I'm somebody who I prescribe, I'm a physician, I prescribe injectables on a lot of my patients, and I like those drugs, and I'm comfortable with those drugs. I don't know much about thermoplasty. I don't know what to do there. My answer is, look, if what you're doing is working for your patients, then why would you change anything? However, if they're not a candidate for those biological drugs because they're labs, what are you offering those people? That's where if you're going to, put this thing to a niche, there it is, right there. Or when you start any intervention, we should be measuring how well they're responding. So if I put you on a new inhaler or an injectable or anything, and your symptom scores don't remotely improve over the next several months to a year, why are we still doing this, right? Why aren't we trying something different?
Another question from Andrew. How do you keep track of the airways that have been treated during a BT procedure? Do they look different?
It's a great question.
Yeah.
No, they don't look different. It's actually when we're training people on the procedure, I think one of the things they expect, is that when we're in there, they're going to see grill marks or something, and that we're barbecuing. No, actually, what's striking is majority of the time when you're doing the procedure is the lack of change that you see. Occasionally you'll have people, you can see the tissue, which is usually pinkish, it blanches a little, looks a little whitish for a period of time. Honestly, it's meticulous documentation of where we're at. So the very beginning of the bronchoscopy, after you're asleep, we go in with the scope and essentially examine your airways and map you out.
A little roadmap.
Yeah. And sort of a plan of attack. Okay, we're going to go here. The airways all have a numbering systems. Okay, we're going to go here first. Blah, 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 then down this next one, come back, go down the next one, and we have the nurse in our room is helping to document where we've been, because obviously we don't want to double treat, we don't want to miss an area either, and so that's how we're able to do it.
How long does one of these take?
It's variable, because of course the number of activations is dependent on your anatomy. Yep. And airways, of the lungs are essentially like a fingerprint. I've never brunked the same set of airways twice in the sense of how they look, on two different people. But roughly 30 minutes is probably the easiest number to throw out there, at least at our institution. We've gotten some patients as low as 20, others an hour. Some of it is dependent on the amount of airway, just the real estate. If you've got big lungs, lots of airways, lots of branches to do, we're going to be in there for a while. Yep. If you're somebody without big lungs and not that many airways, it'll be kind of short.
Joyce has a question. She says, do you get system effects from steroid inhalers? And she was on long-term high-dose oral steroids several years ago to control her asthma.
So for sure on oral steroids, tons of systemic symptoms, right?
Yep.
Obesity, risk for diabetes, suppression of the immune system, thinning of the skin, bruising, all bad.
Yep.
Osteoporosis, of course, cataracts. Inhaled steroids. The higher the dose, obviously the potential high risk for systemic absorption. It does appear that high-dose inhaled steroids potentially does decrease your bone density some, but in some pretty good studies, it doesn't look like it increased the risk for fractures. Maybe you might see some systemic effects in regards to risk for cataracts and things like that. And I say maybe, but it also comes back to, let's, for the sake of discussion, assume that that's for a fact, that an inhaled steroid, let's assume, does over time slightly increase your risk for complications that are systemic. Okay, I don't know if that's true, but let's pretend. I know one thing for sure. Oral steroids for sure will give you all of these. So it's the maybe versus definite. And of course, if you're not on the inhaled corticosteroid, you're gonna end up in that emergency room and needing that prednisone, there's a reason it begins with P, just like poison. So.
All right, I think we're just about out of questions. It's been very interesting.
Oh, good.
Appreciate you.
Are there any other in there that we didn't come up with?
Yeah, let me look. I think we've
yeah, not really.
We've covered most of these.
I think the other thing, just one last thing, at least from our perspective, the idea of our severe asthma program and my colleagues who run the severe asthma program is, this is one of our tools. We got many.
Yep. And
we work with your physician. We're not here to, quote, steal you. We're not here to, you're not going to, let's say you don't live near us. You're happy to come down for the procedure, but you're not coming to see me every 3 months. Good Lord, Dr. Hogarth, you live too far away. Look, if you have a great doctor and that you're working with, who's working with you, I want to work with that person or that nurse practitioner or that PA. And this is a procedure we do. So if you need it, come do it, we'll do it, and then we will gladly have you go back and we'll coordinate. I'd like to see at least once a year, make sure you're doing well, blah, blah, blah.
Sure.
But, we want to work with you and your team. And that's probably the easiest way to put it.
Perfect. Now you have an in-person asthma patient event coming up, I understand.
Yes,
at Ingalls Family Care Center in Flossmoor, and that's from 6 to 7 p.m. on Thursday, May 24th. And what kind of things will happen at that event?
Well, I guess I'm going to basically stand there and answer questions. It's meant to be, I suppose, very similar to this.
Sure.
But less, I guess, this isn't scripted either, but less me just standing here and people being able to ask.
So basically, if you haven't had your questions answered today and you want to meet Dr. Hogarth in person, that's a great time to do that. Again, that's at the Ingalls Family Care Center in Flossmoor, 6 to 7 p.m. on Thursday, May 24th.
Yep.
I want to thank you, first of all, for taking time out of your day to do this.
My pleasure.
It's a great service, and we want to thank you for watching. Also want to let viewers know that this will be saved to Facebook after we get done with the Facebook Live event.
Get rid of Dr. Hogarth.
It'll be up there, and you can take a peek at it. We don't want to get rid of you.
Yeah.
Also, if you want more information, go to UChicagoMedicine.org for appointments. You can also call Tanya, who is your scheduler, at 773-795-9933. Thanks for watching. We appreciate it.
Yeah, I appreciate it. Thanks so much.